So, very good afternoon, everyone, and I'm Dr. Sucharna Dasgupta. I welcome you all. The AOGD Fetal Medicine Subcommittee has organized this webinar on current updates in screening for Down syndromes, the obstetrician's perspective. With increasing awareness about the genetic testing and aneuploidy screening, many women nowadays come to our OPD with different scenarios. So, today our experts are going to make it simpler for everyone how to correctly interpret the results and counsel them accordingly. So I'll now invite Dr. Renu Arora ma'am to introduce our guest of honor, Dr. Achla Batra ma'am. Over to Renu Arora ma'am, please. Renu ma'am.
I think you can start.
Yeah, you can start. Actually, everyone knows, and it's really my pleasure to introduce Dr. Achla Batra. She's a dear friend of mine. She was a professor professor in the Department of Obstetrics and Gynecology of Safdarjung Hospital and present president of AOGD. So we can just proceed. Okay. Welcome, Dr. Achla.
So now I would request Dr. Sumitra Bachani ma'am to invite the experts of this event, Dr. Seema Thakur and Dr. Sanjeevni Khanna ma'am. Over to you ma'am.
Okay. Good afternoon and welcome once again to all of you, and thank you for joining us. And I would like to invite Dr. Seema Thakur madam. She is also the convener and for this webinar, and she has been guiding us. She is a senior consultant genetic and fetal diagnosis, Fortis Hospital, Delhi, and at Rainbow Children Hospital, Delhi, and the Genetic Clinic, Dwarka. And of course, we all know her. Without her, I haven't seen much webinars, without her inputs. So welcome, Seema madam, and ma'am is also the expert for this webinar. And now I would also like to invite Dr. Sanjeevni Khanna ma'am, Sucharna ma'am CV. Yes, ma'am has been, first thing is ma'am has been my teacher in Lady Harding, ma'am. So I know you since then. And since then I've seen you as a very astute teacher, very, your insights and your teaching has always really been very encouraging for all of us. Ma'am is currently the director and head department of Obs-Gynae Fortis Hospital, Shalimar Bagh. And of course, ma'am was originally earlier the professor in the department of Obs-Gynae, LHMC. And ma'am is also a vice president, Indian Association of Gynecological Endoscopists, as she was saying, that is her forte. And welcome, ma'am. Sanjeevni ma'am, we look forward to your expert inputs and your guidance in this webinar. So welcome, Seema Thakur madam and Sanjeevni madam.
So let us start with our first session. The topic for this session is NIPT, widening the net. So how to make it cost effective? For this session, I'd like to invite the chairperson, Dr. Sanjeevni Khanna ma'am and Dr. Anjali Dabral ma'am. Sanjeevni ma'am has already been introduced by Dr. Sumitra. I welcome you ma'am, and please flash the CV of Dr. Anjali ma'am. So ma'am is the second chairperson for this session. Ma'am is the head of the Department of Gynae, BMMC Safdarjung Hospital. She is the faculty of ABPU Delhi. She has published several papers in national, international journal. Ma'am has been awarded the WHO fellowship in high risk pregnancy. And her special area of interest is high risk pregnancy and gynae endoscopy. I welcome you ma'am, and I'd also like to request you to introduce our speaker for this session, Dr. Anita Kaul ma'am. Over to Anjali ma'am.
Good afternoon, everyone, and welcome to this very interesting webinar. Though NIPT is not so new, it's 10 years old, but still we have many misconceptions on how to interpret it. And we are we are fortunate. We have Dr. Anita Kaul to say, shed light on this. So welcome, ma'am, and see your CV on this.
No, it doesn't matter. Thank you.
Welcome, ma'am. Anyway, you're one of the foremost fetal medicine experts. So I'm sure you'll do a very good job. Welcome.
Thank you so much. Thank you, AOGD team. So I'm going to share my screen just now.
Yes, ma'am, sure.
Unlike my remit for this talk actually is how cost effective is it to do the cell-free DNA, the NIPT. I'm not going to discuss so much on the sort of science behind it, but more on the fact that if we have to implement it, how do we go about it, looking at all our sort of various things. So I was thinking that I'd look at the literature from the West, introduce the concept of contingent screening, because that's the way we are going forward. And then what happens in our local practice and what are the changes that can be implemented. So the main thing, I mean, our Indian research papers are not so good at doing cost-effective analysis, and you rely on the Western world. So this particular paper is an excellent paper. They looked at like 100,000 pregnancies, did a lot of mathematical modeling, which was sort of beyond me, looked at it. So any kind of an analysis looks at what is the current practice, and then if you move from the current practice to a different practice, how cost effective is it? So the baseline, the current practice, is always taken as the combined screen, which is doing the NT and the dual marker. So that is considered to be the standard of care, and then you sort of move from there. So they looked at the combined test and then analyzed various decision trees, and they took as 1 in 270 as a high risk cutoff for T21 and 1 in 100 for 18 and 13. So essentially what they said was that when you talk about cost effectiveness, really the economic perspective depends on which part of society you are. I mean, do you talk about the cost to the society, that what is the cost of preventing a birth of a Down syndrome baby? So we talk about direct costs, the costs of, apart from the tests and things, of education, of the healthcare system. And you talk about the indirect costs, the fact that this person may not be able to hold down a job, they may not be able to contribute to society in sort of like doing a work. So they talk about the direct and indirect lifetime costs. So that is what we as a society need to think about. The government, on the other hand, if you think about the government cost of how cost effective is it to do Down syndrome screening test, and using NIPT, they look at more of the direct lifetime costs, like what would be the cost to actually have this, to do the test, the education, the healthcare. This is what they would be looking at. And the payer, the person like us, so we would consider ourselves the payer cost, because our government is not actually using this as a screening thing. Our main concern would be actually how much does the test cost? So really, we need to look at all the three aspects. So if you think about society and the fact that you want to reduce actually the burden of long-term, of direct and indirect costs, really doing a universal NIPT is the most cost-effective method. And again, they looked at very complex detailing of the quality of life, of lots of parameters. And it was that if you actually if you look at making the society healthy, it would be that you would do a universal NIPT. However, for the government, that is not the way we should be going forward. For the government, it is that we should be doing something called the contingent screening, which means that you do the combined test. And then for certain cutoffs, you decide that these are the people who will then go on to have a NIPT. And similarly for the payer. For us also, yes, the combined test is our baseline, but we need to use different cutoffs to say that these are the women who need to do an NIPT, and that's how it'll be cost effective. But
so contingent screening is what we are doing. That is what is the way forward. That is what we should be doing. We should be doing the combined test. And then all of us decide what is the cutoff beyond which you would want to order a NIPT test. And this is known as the intermediate risk. So you say that, well, the high risk is, say, 1 in, like in the paper, they said high risk would be more than 1 in 270. And perhaps those are the people that you'd offer invasive testing to. But between 1 in 270 and an X cutoff, this would be the intermediate risk. And these are the group, the subgroup who should have a NIPT. And beyond that risk, we don't do anything. We just let them go for routine care. So now what are these cutoffs? And what they proposed, if you look from the society point of view, then really you need to set a cutoff about 1 in 1,500 or thereabouts. Whereas if you look from a government point of view, that means that any woman who has a risk between 1 in 270 and 1 in 1,500, this intermediate group, they all should have a NIPT. And the referral rate of that would be quite high at 24%. But, you know, as a society, as a whole community, you would benefit. However, as a government, because it costs a lot, they may say that, look, let's do a cutoff about 1 in 470. So any woman who has a risk between 1 in 270 and 1 in 420, which is about 8%, they are the ones who have NIPT. So you have less people doing it. And we as a consumer, as a payer of the test, as a pregnant woman whom I have to, you know, you have to pay for it yourself, you make the cutoff even tighter, 1 in 300. So, you know, beyond 315, if your risk is, say, 1 in 500 or so, you may well not do anything, because the chances of Down syndrome in that group has dropped down substantially for you not to pay so much to you know, pick up this small risk. Making these assumptions is that not everyone you know, does syndromic screening. But anyway, this was a suggestion of cutoffs. But what's happening in other parts? This is US. So we came now coming down to a more practical aspect, which is the UK. So the UK people said that, okay, as a government, we need to implement this non-invasive prenatal screening. We need to implement, and let's see that in the field, how does this work? And what they decided to do as a cutoff, and this is what I think most of us in Delhi are doing, we're taking a cutoff between 1 in 150 to 1 in 1,000 and saying that this is our intermediate group. So if you do a combined test and the risk is like better than 1 in 1,000, you tend not to do anything. If your risk is in between, like if it is 1 in 700, you tend to tell this lady, well, you are in the intermediate group, and why don't you get a NIPT done? And if your risk is more than 1 in 150, you offer her invasive test. And what they found, and this was a very seminal article which was published in the BMJ, is that if you take 1 in 1,000 cutoff, so if you take this as like a zero line, if every woman who has a risk between 1 in 150 and 1 in 1,000, the risk, the cost of the test goes up hugely. I mean, it's in several million, it costs the government. If you make it tighter, if you say, let's do a 1 in 500 cutoff, and only women between 1 in 150 and 1 in 500 have the NIPT, so the cost comes down much less. But if you offer the test only to the ones who come in the high risk, that means between 1 in 2 to 1 in 50, the cost to the government is not so much. So if you see over here, it's not appreciably more. And because as a result of this research, this is the current guidance for NIPT screening from the UK government, which is updated on September 2021. And they say that if you have a risk between 1 in 2 to 1 in 150, then only will the government pay for you if you don't want to do an invasive test. So you have a choice that you're given. I mean, I think for us, we are much more proactive about saying, no, do a amnio, do a CVS, or do whatever. But at the moment, the UK government says that, no, you have the right to do NIPT, because that will bring down your false positives, because inherent to the combined test, there is a false positive rate of 5% or whatever. It will bring down the false positive rate, and you can then take a thing. But if you have a risk which is better than 1 in 150, you're considered to be low risk, and you don't actually need to do anything much. And this, I think, is the change that we need to bring around. I think, our cutoffs are really too wide, and this is the change we need to bring along. So coming back to the local situation, what are the things that we can do over here? For me, it is making a basic combined test stronger, because we have a very high false positive rate, and we really need to standardize our test so that we bring down our false positive rate. So we need to have quality control on the ultrasound, which I believe that everyone should have, FFMF certification for that. And we need to have quality control on the lab standards. So as the UK is concerned, even the NIPT that they do, that is under quality control. So as they have this UK NECWAS to make sure that the PAPE beta HCG is, there's quality control of the labs who run it. They also have the same for the NIPT. They have this genomic assurance test where they, look at that. So I thought that let me demonstrate, because I still don't think there are enough people who are doing FMF, NT things. So let me just demonstrate, what do I mean without increasing the cost? How can you add more ultrasound markers to change the risk? So over here,
what I mean by using ultrasound markers. So say for this particular patient who had who was 13 weeks, she had a normal CRL, which you can see over here. She had an NT, which was within the normal range, but it was a little bit upper normal, but nevertheless, it was quite well within the normal range. The biochemistry was fine. This was what I'm showing in biochemistry. And her risks, when we calculated, was 1 in 550. So this would be an intermediate risk. But to make it better, I can then say that I have examined the nasal bone, and I can add that to the risk calculation, and that makes it already intermediate. I can say that I have seen the tricuspid, and that's normal, and that also makes it even better. So these ultrasound markers, so this lady who would have been 1 in 550 and intermediate has now become in the low risk zone. So I don't necessarily need to send a cell-free DNA test for her.
So just to tell you, so can you see how easy it is? But, without spending so much more money, that you just have a risk calculation algorithm in the room with you, which is, as I keep telling everyone, that, the FMF risk calculation algorithm is free of charge. It just requires that you should get your certification for it, and you can do all this, and that would help a lot. So it's very reassuring to say, well, your risk is 1 in 3,000. I don't need to do anything. But say, for instance, and this I wanted to say, that say if you don't have ultrasound and you just use blood, I can do the same.
Using ultrasound markers. So say for this particular patient who had who was 13 weeks, she had a normal CRL, which you can see over here.
Oh, sorry, I'm running this again. Sorry, this is biochemistry. So here, what we are doing is the ultrasound markers we are not changing, like I showed you. We're saying that, okay, some people may find it easier to do bloods rather than ultrasound.
With bloods. So now we have exactly the same patient who had that risk of 1 in 550. And here I chose to alter the ultrasound marker. Say someone doesn't want, just doing the dual marker. Say we add a normal PLGF. Then the risk calculation over here could change again. You can see that now it comes out of the risk zone and it again gives back a low risk. And if by chance the biochemistry was even better, it's not 1 moms, but say it is 1.2 moms, the risk becomes 1 in 3,000, so it becomes even better. So with bloods. So now we have exactly the same patient who had that.
So my point is that every time you get an intermediate risk, it's not necessary, because at the moment, as I said, in Delhi, our practice is to take 1 in 1,000 as an intermediate risk. And oftentimes you have a risk of 1 in 600, 700, and you're sending them off for an NIPT. So what I'm saying is that if we just manipulate with the first trimester screen, either we add more bloods or we add more markers, you would automatically improve the risks without spending whatever 15, 16,000, which is the NIPT. So overall, yes, it would be good if the labs bring down the costs of the test, but at the moment, none of the labs have QC. Every day you get a new lab saying, oh, we can give you NIPT for a smaller cost, but there's no quality control. Is it cheaper just to do T21 and say that, look, we don't want the risks for 18 and 13 because that we can find on ultrasound anyway? Or do we do the contingent screening, which is what we are doing, but just tighten the intermediate risks like UK? So where, say, for instance, I'm in my unit, and this is our data, that in my unit where I've taken 1 in 150 to 1 in 1,000 as my intermediate risk, and these are the people we're sending off for NIPT. I mean, just before this talk, I thought, let me just look at our data. And, between the intermediate risk that we've kept, we had 64 patients and not one of them had Downs. And equally, the ones which have a low risk, but they come to us because, they're like an older age group, or they're doctors, or they have no problems in spending money. And because that's a good test, you get it done. The main group where actually we had a high risk was the 1 in 2 to 1 in 50, the ones whom we've done invasive. And it is true, not everyone is keen to have an invasive test. They don't sit there every time, it's an IVF pregnancy, it's this, it's that, they've conceived after a long time, and they are scared of the invasive. And in the group who did do NIPT, which was 20 of them, 40%, I mean, 8 did have T21, but the rest were absolutely fine and they had a live birth. So maybe it is something for us to think about, and think of this UK model for the people who perhaps don't want to do invasives, and perhaps not be so rigid about saying, no, that intermediate risk up to 1,000, we need to get all of them to have NIPT. In our group, we did have false positives, and we had 1 false negative, which was a triploidy. So before I finish, I just want to again remind you that NIPT is a very good test for T21, okayish for 18 and 13. This is what UK, the guidance, the public health guidance recommends, that perhaps after nearly 22 weeks, we don't do it because of the cutoff of termination. Women who have cancer, or who have received a blood transfusion in the previous 4 months, or are on IVIG treatment, or have had a vanished twin pregnancies, these should not have a cell-free DNA testing. And other than that, of course, the ones who have had organ transplants, bone marrow, stem cell, and so forth. And if the parent themselves are a balanced translocation, then they are also not appropriate for NIPT. So this was just to remind you of that, and also to remind you that even though it is a very good test, it is best for Down syndrome, not so good for 18, where only 84% yielded a compatible result. So that if NIPT came positive, only 84% was actually truly T18. And if it came as 13, it was hardly 50%. Which was T18, and similarly for the sex chromosomes. So it needs to be used judiciously. So for me, as a conclusion, I would probably just say the take-home messages for our country, for our scenario, where the government is not involved at the moment. We can't afford to just keep doing the test willy-nilly. If I'm talking about, say, Safdarjung and our public health hospitals, would be that we must make our first trimester really take that. We are very proactive in helping people get their certification and their images and so forth. And if you want help with that, please contact any of these people. Thank you very much for your patient hearing.
Thank you, ma'am. Thank you for this very absorbing talk. Now, I'd like to request Dr. Sanjeevani Khanna, ma'am. Ma'am, please give your expert comment and conclude this session.
I think this was a brilliant presentation by Dr. Anita Kaul, and she has really adhered to her topic. And so for NIPT, which I think should be better called NIPS because it's a screening test. So for that, how to widen the net is actually, and how to make it cost effective. By widening the net, we are actually not widening the number of NIPTs that we do. Rather, we are going to confine the cases that we advise NIPT, so that and rely on a baseline first trimester combined test. So I think she's told us that the standard of care would be the combined test, and also brought to our notice that it is the government cost, the societal cost, and the individual payer costs, which all factor in. And so they all have to be given thought to. And so the contingent screening method is the best way to proceed, rather than the sequential or the integrated. And we follow the contingent system here in our country. Yet we, as of now, have to rely on Western data because there are not too many reports from within our country. But we can get good guidance from the NHS, very crystal clear, and you press one link after another and you can get to specifics. And she's also told us about the cutoffs. So it majorly depends on the cutoffs that we use, and that she has described from her perspective as a super specialist in this field, what cutoffs we should take. So it is very clear to us as obstetricians, because I'm not a geneticist or a fetal medicine specialist, so I have only absorbed what I could from reading and from learning from you all. And of course, Dr. Seema Thakur and Dr. Vatsala Dadwal and so many others have been, the prime sort of inspirations for learning more and more about these things, because somewhere or the other we will have to give an advice. Even if I'm an endoscopic surgeon, I will on occasion have to give advice to a pregnant lady, and I should make sense of it. So I think it is very important that we follow the contingent program, and we take our cutoffs, and so we understand very well that there will emerge a group which is high risk, and where non-invasive or cell-free DNA testing would clearly be advised, of course, with the option of diagnostic testing. So if the patient chooses diagnostic testing after a positive high-risk report, she could choose that in favor of the non-invasive prenatal test as well. And then we have a low-risk group where reassurance and nothing further except for sonography at 18 to 20 weeks. But it's the intermediate risk group which poses problems. So the intermediate group would benefit from non-invasive prenatal test, whereas in the high risk, you would straight away offer diagnostic test like a CVS or an amniocentesis. And also I made note of this, that how to improve the so we can improve the quality control on the ultrasound by training more people and training them by recommended FMF and certified courses. And also we should have quality control on labs, because uh, for business many labs may open up and may have no quality control, and an ultrasonologist may be a very good ultrasonologist but may not be so acute with measuring the nuchal translucency, which is to be measured so accurately with the calipers placed correctly against the fluid at the back of the neck. And so she has uh, also mentioned very nicely about who are the women who should not or uh, cannot be advised in NIPT. And those are the women who have received a blood transfusion in the past 4 months, or those who have received intravenous immune globulin, or those who have a vanishing twin. So we're very clear that at least this much knowledge all of us should have, that we should take this history beforehand and go into details. Now, there's one more. I mean, there is in fact a question I would like to ask of Dr. Kaul, and that is that certain drug intake may also contraindicate in NIPT, and so it is said that if a patient is on low molecular weight heparin, then also we should not do NIPT. And I could not find a reason for that.
Well,
Low fetal fraction, because that causes low fetal fraction, ma'am.
You have low fetal fraction.
Yeah, with
and
but
yes, okay. So beyond
preclude it, I mean, what normally happens, because it's not been listed as an indication for not doing a NIPT. However, if it is a low fetal fraction, when you do your pre-test counseling, you anyway tell them about redraw, or you tell them about failure of 2%. So for me, I would still do it. And if by chance it is a low fetal, I mean, it's a probability that you may have a low fetal fraction.
But what is the reason for the low fetal fraction in women on LM?
No, Seema, you know better. Because we don't, I mean, we don't not do it in women.
We have seen cases, and then I read and found that, okay, because heparin causes low fetal fraction, and probably that is one of the drugs, but mechanism of, and
so it doesn't matter.
I think I would not do it. If you
we are doing it. We are doing it. Yeah, we are doing
it.
Okay.
It's not that.
But if it fails, you have an explanation that you can tell them. We had one case which failed twice, a case of glucose anticoagulant, and then we changed the lab.
Yeah, Dr. Seema, can I add something here?
Yes.
Yeah, sure.
In one of the articles, I can't recall, but it was written that in such patients, to minimize low fetal fraction, you can draw the sample just before administering the next dose of heparin.
Okay.
Yeah, so that is one of the precautions which can be taken in these patients to minimize the incidence of low fetal fraction. But I agree with Dr. Anita that we don't stop taking the samples in these patients.
All right. Okay, Dr. Sangeeta, that's in fact a very good input. And I think I should not take too much time, though I could go on for an hour discussing things which are in my mind. My mind is exploding with the questions and clarifications I'm seeking. But there's just one last point, that Dr. Anita, when you talk about the combined dual test, we understand that is an ultrasound plus biochemistry, and in the biochemical markers, so we take pregnancy associated plasma protein and free beta HCG, or total HCG. We could take total HCG as well.
No, you take free. Total is taken in the second trimester.
All right. So we take total. If we take free beta HCG and pregnancy associated plasma protein. And we know the trends in trisomy 21, 18, and 13 for these markers. And I wanted to know if you're doing the expanded first trimester screen, that is, you're adding on the alpha fetoprotein, the placental growth factor. So when you talk about the combined test, so to say, then are you talking about the expanded first trimester test?
No, the base.
Your basic one.
Basic.
Okay. So if you're doing the basic one,
Right.
a point which we all should know is that trisomy 21's risk is given separately, whereas T18 and T13 risks are reported combined.
No, so ultrasound
often
differentiates the two. That's why when you use the FMF algorithm, that ultrasound can differentiate between 18 and 13. Say, for instance, like, the T13 babies have a really high heart rate, so they have tachycardia. So as soon as you put in a heart rate of maybe 182, 185, it kind of veers more towards it being a T13 rather than a 18. I mean, the point is with Western data is that they look at public health. They're not really bothered. And with us, we are the other end of the spectrum.
Yeah, we pay from our own pocket. So,
yes.
So really, for us,
to be so that's why they're strict about the cutoffs. That's why they're strict about the cutoffs.
So, it used
because the government has to pay. And here the
uh,
public has, so the main difference is that, we are paying from our own pocket. So, probably we'll have to, sit and decide our own guidelines.
Right.
So on perusing these combined dual marker reports with which have included the crown rump length, of course, seen that it's all right, and the nuchal translucency and the two markers, and no further detail taken into the combined test. I was exploring this as to how and why some labs report T18 and 13 risk together. And the reason that I found for that was that T13 is worse than T18 from prognosis point of view. And so because alpha fetoprotein and beta HCG both are low in T18 and T13, so it doesn't matter whether if you've identified just T18, because it's got to be T18 or T13 with the level of the markers. So low AFP and low beta HCG means it could be trisomy 18 or 13. Whereas, of course, in trisomy 21, you'll have a high beta HCG. So they say that it doesn't matter if we segregate the T18 and the T13 groups. Because it used to come to my mind why they can't tell separately. They can't because the marker levels are similar.
Similar, correct.
Yeah.
But which is why combined is important, because you can tell all three separately. But my point is, I'm in the private sector. So for us, we do a expanded because, and we do a sort of intermediate. But I think Sumitra was saying that we need to speak more for the masses rather than sort of isolated groups like, at Fortis or at Apollo. But what is good for the general, and for the good for the general would be the combined test, but the person who's scanning should be FMF, because they can keep modifying. So once they have the blood and they realize it's intermediate, they just have to add another marker, and then you convert this person who is going to be worried to someone who's not going to be worried.
I feel that Dr. Anita, that it is obstetricians and gynecologists are no longer even generalists, general obstetricians and gynecologists are no longer the sort who should be given very abbreviated information because they are general OBG, because many of them have a lot of information and many of them crave for more. So I think, whatever, and they are seeing reports with T21 reported separately and T13, 18, and the question comes to their mind. Few people have shared it with me that why is T18 and 13 reported together? So this is the reason I found for it. And I can strike my mind. I'm sure it must be striking the minds of so many general people amongst in our profession. So I think I must not be selfish anymore. And this talk of the non-invasive prenatal test, widening its net and how to make it cost effective was certainly a daunting task. And Dr. Anita has put it in a perfect way. and it has really sunk home and made complete sense. So thank you so much, Dr. Anita. And back to Dr. Suchandana, Dr. Sumitra for proceeding. Thank you.
Thank you.
Thank you, ma'am.
Thank you.
So moving on, we will be proceeding to our second session. The topic is interpreting the biomarkers. To chair this session, I'd like to invite Dr. Bindu Bajaj ma'am and Dr. Josna Suri ma'am. Dr. Bindu Bajaj ma'am is the professor and consultant in VMMC Safdarjung Hospital. She has done the WHO fellowship in high-risk pregnancy. Her area of interest is infertility and laparoscopy. Ma'am is trained in ART. Ma'am has been the member of various societies like AOGD, FOXY, IFS, DGS, and she has published many journals and publications, reviewed many articles. I welcome you, ma'am. And the second chairperson is Dr. Josna Suri, ma'am. Ma'am is the professor and consultant in Department of Obstetric and Gynecology, VMMC Safdarjung Hospital. She is the in charge of critical care obstetrics, VMMC and Safdarjung Hospital. She is the faculty in National Board, IPU and Delhi University. Ma'am has held many prestigious posts in AOGD in the past. She is the past editor in AOGD Narchi. Ma'am has various chapters in various textbooks. She has also edited and co-authored the book on practical approach to critical care in obstetric. Ma'am has been awarded many awards and published many papers in national and international journals. I welcome you, ma'am. And I'd like to request Dr. Bindu ma'am now to introduce the speaker for us for our next session, Dr. Vatsala ma'am. So over to Bindu ma'am.
Thank you so much. Thanks. First of all, I would like to thank for inviting me here, and I would wholeheartedly agree with Dr. Sanjeevani, madam, that we ought to know more. As in infertility specialist, also once the patient becomes pregnant, she has so much faith in you. She wants to know so much from you, and we ought to know it. And introducing Dr. Vatsala Dadwal, who everybody knows that she is such a doctor of eminence. She is the professor, Division of Maternal Fetal Medicine Division in Department of Obs and Gynae at All India Institute of Medical Sciences. She has many awards and honors to her credit and multiple publications, 160 papers in peer-reviewed journals, 200 presentations in international and national conferences. In her special interest field are fetal medicine, diagnostic and therapeutic interventions, including intrauterine transfusions, lasers for triple TS and RFF for fetal reduction, and ultrasound in the first trimester, and AMNI scan and fetal echo. Welcome, madam. Kindly come and give the talk.
Thank you, ma'am. Thank you, Dr. Bindu, for the kind introduction. And I'll just share my slide. And I'd like to thank Dr. Sumitra and the organizers for giving me this opportunity to be here. And I was to talk on the biochemical markers for aneuploidy screening. So I don't know, maybe a little bit of repetition. So this is some of the aspects I would be covering in my talk. So we all know the rationale for screening for Down syndrome, and we know that not only Down syndrome, the screening test also pick up other common aneuploidies. And we know that screening tests can tell the probability of the condition, and anyone who's screen positive needs to have a diagnostic test. Screening test is not a diagnostic test, and all women should be given the option of screening and information and performance of the test available so that she can make an informed choice. And the choice of test will also depend on the gestational age at which she has presented and the test available to us in that situation. For a combined test, it is important to have a good NT scan. So if it's not available, it's better to go on to the second trimester cord screen, or you could go for a penta screen. But again, then you have to understand the performance of each test. And there is no doubt that all women should be offered antenatal screening for aneuploidy. So there are certain terms that we use, like what is a risk cutoff. I think Dr. Anita was just trying to explain to us. Detection rate, false positives, multiple of medians. When we are looking at the report, when the serum markers are in, the values are put as absolute value and multiple of median. Then what is the odds of affected pregnancy ratio? So these are some of the terms that we commonly used when we are interpreting the test and we are talking to the patient to make them understand what the test means. So screen positive rate is a percentage of individuals with a positive result on the test. So if we have 95 pregnancies and 9 are positive, the screen positive rate is around 4.6%. And mostly for a screening test, we like to have a screen positive rate not more than 5%. And detection rate is the percentage of affected individuals who would be actually picked up on that test. So if there are 5 affected individuals and we pick up only 3, that is 3 out of 5 are affected, picked up. So the detection rate for the test is only 60%. And for a screening test, we know that a detection rate of at least 75% should be there to make it a good screening test. Then false positive rates of a test. And we know that we should not have more than a certain false positive, not more than a 3 or 5% false positive rate for the test, because it is a false positive, which would be unnecessary invasives or going for further testing. So if you have like 190 population of 190 and 6 of the 190 unaffected pregnancies are screen positive, then it is a false positive rate of 3% that they were not having the disease, but they were picked up as positive on the screen. Then the other important is odds of affected with a positive result. We know that when we're doing a screening test, we have a detection rate, that is a number of individuals actually having the disease that gets picked up, but we'll also have a certain individuals who are not having the disease also gets picked up. So when you talk about the positive predictive value or odds of affected with a positive result, suppose we have 9 pregnancies which are called screen positive by the test, but only 3 are actually affected. So the positive predictive value is 33%. So the rest of them would be false positive, and only 1 in 3 will actually have the disease. Other 2 will come as positive and would need a diagnostic test, which may be unnecessary. So for a screening test to be good, it should have a high positive predictive value, a good detection rate, and a low false positive rate. So how is the risk cutoff established? So we have to trade between the detection rate, that is the number of cases that which can be detected by the test, and the number of false positives we are going to have, which is usually taken around 5%. So for like when we take a cutoff of 1 in 250, then it is a say 70% detection rate at a 5% false positive rate. So it's a trade-off between your detection rate and a false positive to get a cutoff rate for a performance of a screening test. So coming to the serum analytes, we are using serum analytes in the first trimester as well as second trimester biochemical screening for Down syndrome or aneuploidies, you can say. So these have all these biochemical markers have a certain trend in pregnancy. So the estriol would increase as gestation advances. Inhibin has a diphasic curve. And again, alpha-fetoprotein is increasing, HCs is decreasing in pregnancy. So here is also the importance of knowing the gestational age correctly, because we know that these values are going to change across the gestation. And what happens in Down syndrome, estriol is less, inhibin is increased, alpha-fetoprotein is decreased, and HCG is increased. So if you have a pregnancy which is actually 18, which is you sort of take her gestation as 18 and get a value, but actually she is 16 weeks, so you get a lower value. But if you interpret that lower value for that being at 18 weeks, then you would get a false positive for that patient. So these things are important when you're interpreting the serum analytes. They're all gestational age dependent. So giving the gestational age or dating pregnancy is very important in interpreting serum analytes. And when we come for the first trimester, PAPE, again, we know it increases during pregnancy in the first trimester, but in Down syndrome, it is reduced. And it is usually cutoff of 0.4 is taken. And for beta HCG also, it decreases as gestation advances. But in Down syndrome, the values are higher, almost twice the normal. So the markers are measured as units and also converted into multiple of medians. And for converting of multiple of medians, advantage is that you can compare the value across gestational age, because we know the values keep changing as the gestation increases. And again, that dating is very important because all the biochemical markers have to be interpreted based on the gestational age, because they keep changing with gestational age. So how do these markers behave? So in the first trimester for Down syndrome, you'll have PAPE decrease, beta HCG increase, and the NT would be decreased. Whereas for trisomy 18 and 13, both PAPA and beta HCG are decreased and NT is increased. Whereas in the second trimester for Down syndrome, alpha-fetoprotein, estriol is decreased and HCG and inhibin are increased. So this is around 70%, 30% decrease. So 0.7 is the cutoff for these two values, and these are almost twice the normal. Whereas for trisomy 18, alpha-fetoprotein is increased, estriol and HCG is increased, but inhibin doesn't have a discriminatory value. Similarly, for trisomy 13, they may not have. Other conditions which can be detected on and as abnormal biochemical screening in the first and second trimester are Turner syndrome, triploides, and other certain conditions like Smith-Lemli-Optis syndrome, which has very low levels of estriol. So that is the advantage of biochemical screening, because some of these abnormalities may not be picked up on NIPT, can be picked up. And again, very low estriol may be associated with X-linked ichthyosis, CAH, or sulfatase deficiency. So methods of screening has already been highlighted in the first trimester. It is always combined screening, NT with the biochemical markers. If you have the two markers, it is dual screen. If you add more markers, it becomes enhanced screen. And again, as Madam Dr. Anita Kaul emphasized, that if you add additional markers on ultrasound, you increase the detection rate and you decrease the false positives. Second trimester, you can use serum markers. You can use either triple, you can use quadruple, or you can use 5 markers penta screen, and then you have NIPT. So this is a spectrum of screening tests that we use. The most commonly used in the first trimester is the combined screening, and that has a better detection rate than using the triple or quad test. Penta may have a higher detection rate. So how do these tests perform? In the first trimester, the detection rate is around 85%, triple screen is just 70%, quad is 81%. The integrated sequential and contingent screening perform better. And only NT will not have that much of a detection rate, only 65%. So in first trimester, it is always a combined screening. And talking about the odds of affected pregnancy when the test is positive. So if you have a better test, the odds will be low. So when you're using integrated and serum integrated test, you will be doing, for a positive case, the chance of the baby affected is 1 in 5. So you do only 4 extra procedures here. For a combined screening, it is like 1 in 20. So for 20 screen positives, if you go ahead and do invasive, you'll have only 1 case of Down syndrome. So this is how we can look at the performance of the test, the sensitivity, the positive predictive value, and odds of affected pregnancy once the test is positive. So again, like if you have only maternal age, or if you add NT, you add 2 markers, or you add other markers, the detection rate improves. So interpretation, we have a woman has a priority risk depending upon her age and for that gestational age, and that risk is modified by multiplying with the likelihood ratio of each of the markers depending on how the value are distributed for that marker for that patient. Other thing we need to understand beside the age of the mother, the gestational age, and the previous history of Down syndrome is the adjustment of mom values of these biochemical markers in different conditions. Like if you have a mother who is overweight, then the biochemical markers are likely to be lower and you have to make those adjustments. The software automatically makes the adjustment. For women on insulin-dependent diabetic, again, the alpha-fetoprotein and estriol values are lower. The first trimester values may not be affected. In smokers, the values are lower, that is beta HCG and PAPA. So these things have to be kept in mind, and this information should be given to the lab when you're sending the patient for the test. Ethnicity may also have an effect. Again, ART pregnancies have lower PAPA and higher beta HCG. So if you don't inform the lab that it is an ART pregnancy, you'll have a false positive value and a screen positive for Down syndrome. But again, it doesn't have much effect on the inhibin and alpha-fetoprotein. Again, if it is a vanishing twin, then we will not like to do first trimester screening because the biochemical markers are affected. Then we can go by NT. That would be a better option. So if you have a screen positive fetus, then we have to discuss about the diagnostic testing, or we can do a contingency by going for a cell-free DNA for the intermediate risk. If you're taking a high risk as 1 in 100 and 150 and a low risk beyond 1 in 1000, then the intermediate can also go for a cell-free DNA that has already been highlighted. When a patient is screen negative, we always tell her that she's at a low risk of Down syndrome, but we can never say that a baby is absolutely normal. We cannot say the karyotype is going to be absolutely normal because every test would have some false negatives and we can miss out certain cases. So this has already been discussed, how we can triage or how we get the cutoff values in the first trimester. And I think Dr. Anita has already discussed these things, so I won't go into details. Coming to the twins, yes, biochemical markers can be used in twin pregnancy for screening, but here the zygosity is important. In monozygotic twins, we know that either both will be affected or not affected. And combined screening is an ideal tool in twin pregnancies because you have an NT, which is a discriminatory marker. In a monochorionic twin, we would average the NT and calculate a risk for a single pregnancy. Whereas in a dichorionic pregnancy, for each fetus, its own NT and CRL can be used to individualize the risk. As far as the biochemical markers are concerned, we would average the value and make it like a singleton pregnancy. We cannot differentiate how much is coming from each twin. So these can be averaged. For free beta HCG, it's divided by 2. PAPE is also divided by 2.1, and for dichorionic and 1.7 for monochorionic pregnancies. And that's how we can calculate the risk for aneuploidy. This will not happen if you're using the biochemical screening in the second trimester, because again, you would be averaging the biochemical markers as of singleton pregnancy and then calculating the risk for the twins. And we are not able to know, like the biochemical marker is either raised by one twin or a decrease in the other twin, or a decrease and increase in the other may balance out. So NT is the most important discriminatory factor here in assigning proper risk in twins. So we can definitely use combined screening for twins in both monochorionic and dichorionic twin, and it also gives a good detection rate, especially for monochorionic. It is almost as good as the singleton pregnancy. So coming to the other test, like if you're using multiple marker enhanced test, then if you're using only biochemical test, then it has a good detection rate, but the false positives are high. So you may use a reflexive DNA testing for these patients who have a high risk, but again, that will be a lot of women undergoing a non-invasive prenatal screening because of false positives here are very high. But we're using expanded conventional screening, including NT, then the detection rate is very high and the false positive rates are very low. So it acts as a good screening test. So to conclude, all women should be offered aneuploidy screening irrespective of maternal age. Which test to use, the performance of the test should be discussed with the patient, and it will also depend at to what time she's presenting to us during pregnancy, because in our public hospitals, patients do present late. They may not come in the first trimester. First trimester screening would be a better screening if you're using a biochemical screening test, but it has to be combined with NT. It's no point doing just biochemical screening in the first trimester, because if you're using PAPE and HCG only, the detection rate is very low. So it should not be used, always combined with the NT. And again, pre-test and post-test counseling is very important, which I have not really covered here. And we need to understand, the patients also need to understand that the screening test is not a diagnostic test. If the screen is positive, doesn't mean the baby is effective. She has to undergo a diagnostic test. A screen test negative may not always mean that the baby is absolutely normal. So all these things need to be understood by us also to counsel the patient. Thank you so much.
Thank you, ma'am. I'd like to invite now Dr. Jyotsna Suri, ma'am, to give her expert opinion and conclude this session. Ma'am, please unmute. Jyotsna, ma'am, unmute.
Yeah, thank you. Thank you, Suchanna. So Dr. Vatsala, it was a wonderful talk as usual. And especially, I really like the way you described all the statistical, definitions and with the examples. So it was very, very clear for everybody. And the important thing which you highlighted, which is so important for the clinicians, we are all practicing obstetricians, but when we refer the patient to the lab, we should be very, very sure about the gestational age. I think that is one thing which you highlighted. And second is that what are the other factors on which the biomarkers could depend such as if she is a insulin dependent diabetic. Is it only for insulin dependent, or type 2 diabetics also, does it change?
I think diabetics across all.
Only
insulin. Only insulin.
Yeah.
Only insulin.
Only insulin.
Okay. So, okay. So that is another thing which I think we all as clinicians should not forget to mention, and whether they had an ART pregnancy or not. So all those things are very, very important. I think I have learned a lot of things from your talk today, and we should not forget to note down these things in our form when we are referring the patient. One thing which I wanted to ask, in the first trimester screen, we see many patients are on HCG, especially those who have conceived by the ART. So will it change the interpretation, or what is to be done? We are to stop the HCG before we send the patient, or how do we go about?
Yeah, if the patient is on HCG, it may affect the HCG values. So I think we'll have to inform the lab about if the patient is on HCG. But I think no one really puts patients on HCG nowadays.
No, I see many patients are coming, after ART.
But that can be a factor which can affect the result, yes.
ART is in their tick box, where the insulin and everything is given. So this is one of those maternal characteristics. So you have to tick box, into that box also, that whether this is an IVF pregnancy. So that will take care, because IVF does affect the, biochemical.
Dr. Seema, if they're getting exogenous extra exogenous HCG at such ART pregnancies,
then there are few labs, still they would, but it's better keep dene se just pehle, again like heparin only, last injection se just pehle de de.
This so that you take care of the half-life of the
injection. Half-life, yeah.
Okay, and I don't think progesterone will not make a difference, right?
No, progesterone may not.
Yeah. Okay. And of course, I think in the twins, you have stressed that NT is the most important discriminator. So we should not forget to do it in the first trimester screen is most important for them.
It's the best time to screen the twins, not wait for the second trimester.
Yeah. So I think, are there any questions from the audience? We can take them. Otherwise, we can go on to the next session. It has been a wonderful session. Both the speakers have done really well and given really very, very crisp take-home messages. So, Suchanna, no question?
Do the question answer session at the last, ma'am.
Okay, so I hand it over to you for the next session, please.
Thank you, ma'am. So I'll hand over further to Dr. Anna, my co-fellow, for the further proceedings. Over to you, Anna.
Thank you, Suchanna, and a very good afternoon to all the respected faculty. We next have a panel discussion on common scenarios in our obstetric OPD. And to moderate the session, I would like to invite Dr. Renu Arora, ma'am. Ma'am is the professor consultant and in charge of fetal medicine services in Safdarjung Hospital, New Delhi, has more than 30 years of experience in postgraduate and undergraduate teaching. Her key area of interest are fetal medicine, high-risk pregnancy, and academic and research works. She has guided multiple MS theses, has been co-investigator in multiple ICMR PhD theses, has more than 55 publications in various national and international journals. I welcome you, ma'am.
Thank you.
I also invite Dr. Sumitra Bachani, ma'am. Sumitra ma'am is professor and senior specialist in BMNC Safdarjung Hospital, New Delhi, and is a faculty in fetal medicine and genetic clinic, NB teacher for FNB trainees, nodal officer for COVID facility in SJ Hospital, member of DAC PC PNDT South Delhi, has been joint secretary of AOGD and is a current web editor in AOGD, executive committee member of Society of Fetal Medicine and secretary SFM Delhi chapter. Her field of interest are fetal medicine, gestational genetics, and high-risk pregnancy. I welcome you, ma'am. I move on to invite our esteemed panelists for today's session, Dr. Sangeeta Gupta, ma'am. Ma'am is the Director Professor OBGY in Maulana Azad Medical College, New Delhi. She has established the fetal medicine clinic at MAMC and Loknayak Hospital, was awarded Commonwealth Scholarship and was trained in fetal medicine at St. George's Hospital, London, faculty of FNB training program, expert member National Board and UPSC, holds multiple publication and contributions in various textbooks, has been the editor and joint secretary AOGD, co-chairperson Fetal Medicine Subcommittee AOGD, executive member SFM, secretary NACHI. I welcome you, ma'am. Next, I invite Dr. Manisha Kumar, ma'am. Ma'am is the Director Professor, Department of OBGYN, Lady Hardinge Medical College, New Delhi, in charge of Fetal Medicine and Genetic Lab at LHMC. Her ongoing research works are risk stratification of preeclampsia, placental profile markers, birth defects, and artificial intelligence application in hypertensive disorder. I welcome you, ma'am. Our next panelist is Professor Reema Kumar Bhatt, Senior Fetal Medicine Consultant at Cloud9 Hospital, and has served as a senior advisor in prestigious Army Hospital Research and Referral for 8 years and in Armed Forces for 23 years. She is an executive member of SFM, has been co-chairperson of AOGD Subcommittee of Fetal Medicine, chairperson Fetal Therapy SFM, joint editor of Journal of Fetal Medicine, has numerous publications in national and international journals. I welcome you, ma'am. Dr. Jaya Chavla, ma'am, Associate Professor, Department of Obs and Gynae, RML Hospital, Fellow Maternal and Fetal Medicine, AIMS, Fellow Indian College of Maternal Child Health, Reviewer of Journal of Fetal Medicine. Her field of interest are fetal cardiac arrhythmia and prenatal screening. I welcome you, ma'am. Dr. Sunita Verma, ma'am. Ma'am is Director, Department of Obs and Gynae, Fortis Hospital, Shalimar Bagh. She has more than 30 years of experience in the field past President DGF, established the Department of Obs and Gynae at Max Hospital, academically active as a teacher and guide to DNB students. Special area of interest are high-risk pregnancy, minimal access surgery, especially single incision laparoscopy. I welcome you, ma'am. I now invite ma'am for the discussion.
Thank you, Dr. Anna, for inviting all of us and also the panelists. And we welcome all the panelists. So we'll just, and following this great discussion and both these lectures by Dr. Anita Cole and by Dr. Vatsala, it was really full of lot of information. And I just want to say that we will be using all this information while discussing the case scenario now. And we will be reiterating and readdressing the same issues. So please stay with us. So prenatal screening for T21, which is a common scenario in obstetrical OPD practice. Fetal screening, as Dr. Vatsala has already pointed out, means this screening is a process of surveying a population which is using a specific marker or markers to identify the individual in the population at risk. And following that, we calculate the risk for a particular individual. And fetal aneuploidy just means that it may be an extra chromosome or it may be one chromosome, and the outcome of the fetal of the aneuploidy may be a non-viable pregnancy, maybe birth defect, failure to thrive, or intellectual disability. And as Dr. Vatsala has already pointed out, that every woman has a risk of having a baby with chromosomal defect. And this is called a priori risk. And this risk depends upon the maternal age and the gestational age. And this risk then is later on modified. So next slide, please, because I would not like to go on to the screening test. Ideal has also been dealt with by Dr. Vatsala. And I just want to say here that most of the screening tests that we are using to identify the T21 do comply with somehow with the ideal screening test, most of the tests. So they are very good because they are cost effective, and we really have some diagnostic tests also available to validate those screening tests. So first case is Mrs. X. She's 28 years old, primary gravida. She's 11 weeks plus 5 days pregnant now, and ultrasound has been done. And her NT is 1.8, which is around 50th centile, and there is no other structural abnormality. Now from Dr. Sangeeta Gupta, I would like to know that this is a normal pregnancy. So should this woman also be advised screening strategy, or would you like that this should be universal, that every woman should be advised a screening for T21 or any other aneuploidy? What is your take on this?
So good evening, everybody, and I'd like to thank Dr. Renu and Dr. Sumitra for having me here. So first of all, Dr. Renu, ideally, yes, all women are at a risk of aneuploidy, and we should offer aneuploidy screening to all women. However, having said that, there are limitations of settings also. Because sonography and biochemical marker labs are not so freely available everywhere. And particularly in our country, in the rural and the suburb areas, it is very difficult to find sonographers who are trained enough for the equipment which is required to do a NT and CRL, which can match the FMF standards or any international standards, is quite difficult. So it is a limitation of the person who's going to perform, limitation of the equipment, limitation of the lab, and last of all, the cost factor. So far in Indian setup, the government has no policy and is silent on the aneuploidy screening policy. And the volume which it would have to deal in the public sector is quite significant. And even in the private sector, cost is an inhibiting factor. It is not possible for all people seeking care in the private sector to afford this. And besides that, in our country, it is the overwhelming numbers of patients which we have, which limits it. So for every country or every setting, we have to have guidelines. India is already having a very heterogeneous kind of healthcare facility. So we have to find our own way. And I don't think in the current scenario, it is possible for us to have it as a universal screening policy in public sectors.
Like everyone wants a healthy baby at the end of it. What information should you provide while sending these biochemical analyte?
So part of it has already been covered by Dr.
Yes, it has been covered
in her
Still
talk.
We want to revise it.
Yeah. So it is very, very important that we put the correct gestational age. This is the most important thing. At the correct gestational age, according to me, is not only important for aneuploidy screening, but for all obstetric management, whether you're going to later on manage an Rh negative pregnancy, FGR, anything. So I think one message I want to give here is that a dating ultrasound, ideally up to 13 plus 6 weeks, and if not possible in that, up to 16 weeks, should be there with every antenatal woman who reports within this gestational age. Number two, some of the factors which Dr. Vatsala has very nicely pointed out are the factors which modify your biomarkers, like the weight of the woman, her diabetic status, smoking, etc., ethnicity. Then whether it is a singleton or multiple pregnancy, what type of pregnancy, monochorionic or dichorionic twins. And it is very important that when we send this combined screening to a lab or to an ultrasonologist, we should check that the person who's going to perform the scan is an FMF accredited sonographer, and the lab is also accredited. So it is very important to have a knowledge and to look for the software which is being used to do these biomarkers. So these are just to enumerate a few. And I would also add that if it is a twin pregnancy, then for general obstetricians, it would be a very good idea that whenever they are going to send these patients for the first trimester screening, they should take the help of the fetal medicine specialists also.
Yes. So how do you proceed with the counseling? I mean, what do you do? How do you proceed then?
Yeah, so Dr. Renu, in fact, this counseling is a very detailed kind of a procedure. And first, most important thing to tell the patient is that what is trisomy 21 or 13 or 18 or the disorder for which we are going to screen the patient. So when it comes to aneuploidies, broadly, it is going to involve structural abnormalities, intellectual disability, failure to thrive, birth defects, or shortened lifespans. So this is a very important part of the counseling. This is what the counseling should start with. Number two, we should tell the patient that there are not only, when we start with the pre-test counseling, it is not only the screening test which is to be offered. Actually, the ACOG says that every woman should be offered both screening and diagnostic tests. So, but here I limit myself to the screening test only because that's what the panel is concerned about. We should apprise the woman that a screening test, if what is a screening test, it is not a diagnostic test. And if the woman is a high risk at screening, she will need further testing to confirm or refute the diagnosis. And we should tell her that always a screening test positive always does not mean the fetus will be affected. And a low risk screening test does not mean that the baby cannot be affected. So we are just going to pick up the very high risk women out of the screening test, and then they will be subjected to further screening. Then we should also talk about, whenever we are talking about screening, we should also take the background of her family history into account and her past history into account. A woman who has a family which has some other genetic disorders may change your line of action. Say if during the course of your history taking, you figure out that they are suffering from some other genetic disorders also, they may need addressal directly from a invasive testing, and here maybe screening test for aneuploidy is not meaningful, because if you are going to do a diagnostic test, you may as well do the aneuploidy testing there. Women with recurrent abortions may be carriers of translocations. So all these things need to be kept in mind. We should also tell the patient very clearly what we are going to screen for and what we are not going to screen her for. When you talk of aneuploidy screening, it is not going to talk of single gene disorders, because many of my patients, once they get the test reports, even of screening, they'll get back to me and ask, now everything is going to be okay in the baby. So then it's very unfair to tell the patient that we are going to. So these should be, and all the options of screening which Dr. Vatsala has already talked of, including NIPS, should be told to the patients. Its limitations should be discussed there and then. And we should also take the patient a little further. What will be done if the patient is screened positive? What does diagnostic testing mean? And what will be her reproductive options after these diagnostic tests, if at all a fetus is affected? And the timelines should be very clearly told to the patient, because we have a limit of 24 weeks for terminations of pregnancy. So what time a particular test will be taking should also be discussed. And all this discussion should be completely non-directive, which should empower the couple to make their own decisions about what test, whether they want to get any screening done or not, and if yes, what screening test they opt for.
Yes, actually, this screening, pre-test screening is very, very important and elaborate and will take a lot of time. Another thing I just wanted to ask, now this patient has normal NT. Should we do first ultrasound and do biochemical only in case NT is higher or abnormal? And with normal NT, can we just not do biochemical analysis? What is your take on that?
So Dr. Renu, for scenarios like public sectors where we are working, this could be a good contingency method which we could be using. Say a patient who has a normal NT scan, and if we have the facilities for a biochemical screening, that's the best thing to have. It should always be combined. But yes, there is a lot of debate, and one of these can be used again as a preliminary or a basic test, and one can step up and use it as a contingency test also. So that ideal is to do a combined test. Ideal is always to do a combined test. One should always do an NT scan first, because if you pick up some structural abnormalities, then there is no role of dual testing, and one may have to opt for further genetic counseling and detailed ultrasound and invasive testing. But ideal is always that one should have a scan, have a good CRL, NT and other ultrasound markers, and then go ahead with the biochemistry also.
Yes, so both things are important, because NT itself can pick up only 30 to 40% of the patients. We might be missing loads of the other patients. So biochemical should also be added as a part of the screening, and combined should be offered. So
yeah,
Dr.
because we have all Dr. Vatsala said that unless there is a detection rate of 75%, No
Yes.
test is supposed to be good. So individually, they don't perform that well. And when they are combined, the performance is much more than
Yes.
75%.
Yeah, so that's very important, and that's what has to be told to all the obstetricians who all are practicing. Just simple anti will not work, so it has to be a combined test. So now, Dr. Sunita Verma, what is an ideal time for the first trimester combined screening?
Okay, good afternoon, everybody, and thank you so much for involving me with so many stalwarts. I really feel very honored. Actually, when we talk of combined screening, we are talking about the NT scan as well as the biomarkers. Now, NT scan, we all know, is done between 11 to 13 plus 6 weeks, and which is a CRL of 45 to 84 mm. But if you know, so this gives us a wide thing. Should we do it at 11 weeks? Should we do it at 12 weeks? Or should we do it at 13 weeks? Or should we do it at 14 weeks? Now, it's been found with studies that a CRL of 63 mm, which is about 12 weeks, gives you the best sensitivity for nuchal translucency measurement. Also, it would give you a window of opportunity to look for other structural abnormalities, because before this time, you would not be able to really see bladder anomalies or even anencephaly or omphaloceal very clearly. So 12 weeks would be the ideal time to do a NT scan. As far as the biomarkers are concerned, the best time is 10 weeks, because the PAPE increases a little by 12 weeks. So it would not be as low as at 12 weeks as it would be at 10 weeks. Ideally, we would do a biomarker at 10 and an NT scan at 12 weeks. But for convenience sake, most of us do it at 12 weeks, because it's very difficult to, explain to patients to have a test at 10 weeks and then have it again at 12 weeks and then to integrate the two together.
Yes, that's very important. Actually, performance of PAP will increase with the gestational age, but is optimum around 11. And as far as HCG is concerned, it decreases. So then when both are balanced, then 11 weeks is also good for the biochemical, but for ultrasound, definitely 12. So in case you have to call patient, then 12 weeks is an optimum time. So whenever you get the report, Dr. Sunita, then what all will you look in the report?
So I think most of this has been covered, but just to revise. So when you look at the form, you must see that all the correct information has been put in. So most important is the patient's age, the gestational age, the correct CRL has been put in. You have put in the history of any previous trisomy 21 or any other genetic disorders in the patient, history of diabetes mellitus, history of smoking. Also, ethnicity is very important, though obviously all our patients are Indian, but still you might have the odd patient who is not from India. Important is also to see that FHR has been put in. Dr. Anita has pointed out that some aneuploidies present with tachycardia, others with bradycardia. Also, one must make sure that if it's a IVF pregnancy, that should be noted. And very, very important is whether it's a donor egg or the own egg of the patient, because a lot of times this information is withheld even from the doctors. So a 42-year-old patient may come with an IVF pregnancy and tell us that it's her own egg. She may not even disclose it, and we may have wrong risk values. When we look at the moms, as Dr. Vatsala and Dr. Anita have both pointed out, you look at the PAPE mom, a low PAPE mom would be significant for trisomy 21. Also, it would be a biomarker for preeclampsia and fetal growth restriction. Look at the free beta HCG moms. So a low beta HCG mom, less than 0.4 or more than 2.5 would be significant for aneuploidy detection. Also, look at your NT films, your NT value, whether it has been correctly mentioned. A lot of times we find misprints in the NT reports, so make sure to look at the film and see, it might be written as 1.1 centimeter, but actually it might be just 0.1 centimeter, which is just 1 millimeter. So there's a lot of difference between the two values. And of course, look at the risk score. Once you've seen that all this information is correct, your moms have been looked at, you look at the risk score, and then you would divide it into the low risk, the high risk, and the intermediate risk, fit it into your algorithm, and then decide what has to be done further.
Usually that reports come with whenever the patient gets the report, but then we should also look at MOMs and all these values, because they are more reassuring and you can counsel the patient also.
Sometimes you may get a screening, screen risk score, which is not too bad, but when you look at the moms, they are very highly abnormal. So, they
Yes,
should be looked into. Yeah.
yes, many a times we do, because sometimes if we just read low risk, that should not suffice.
Yes.
Yeah, that's very right. Yes, next slide. So can we add some other markers also to improve the predictability of our...
Yes. So we can, add some ultrasound markers, so which Dr. Anita has already mentioned. So the most important is the nasal bone, the ductus venosus flow. So we look at the ductus venosus flow not just as a reversal of A wave, but you look at the resistance to the flow. So you look at, even if there's an increased PI, that would be significant. You look at the tricuspid flows, so presence of regurgitation would be important. So when you add these markers to your combined test, your sensitivity goes up to almost 98%, 95 to 98%, with a very low false positive, 2.5% or so. So most of, addition of markers would reduce your false positive and improve your detection rate. And as far as biochemical markers are concerned, as Dr. Vatsala pointed out, you can add to your PAPE and free beta HCG, you can add the alpha fetoprotein, you can add the PIGF, which would also give you a preeclampsia screening, and that is called the first trimester quadruple marker. Or you could make it the penta marker, where you also add the dimeric inhibin A. So that would give you a sensitivity of almost 98% with only a 1% false positive, which is almost equivalent to an NIPT. So adding markers the more markers that you add, and of course, as Dr. Anita pointed out, Dr. Vatsala pointed out, if you have any soft markers, so you can add those likelihood ratios to the risk calculation, and your risks would, you would get a more fine-tuned risk as compared to just a combined marker.
Yes, thank you. So, Dr. Manisha, what is the FMF algorithm for the first trimester combined screening? How do we proceed regarding the risk scoring?
Good evening, everyone, and thank you, Dr. Renu and Dr. Sumitra, for having me here. So about the FMF software, we have already learned from Dr. Anita, and she has very beautifully explained and even demonstrated us. So basically about the FMF software, I would like to tell everyone that it is in our hand. So whatever values we are going to enter, and we enter the values whatever the lab has given us, so we can enter that, we can check the age, so it just reaffirms, and it also tells us what to do, as you are showing here. So it also tells us whether the patient lies in low risk, intermediate risk, and high risk. So basically it is and it gives us a choice of platform also, which you have got a test done like PAPE and free beta HCG, either from PerkinElmer or from Roche. So you can put in, so it combines everything. So that is good about the FMF software. And as about the risk, they divide, like the main intention is to decrease the invasive procedures, and at the same time increase the detection rate. So in this, they divide basically into the contingents. So the population is divided into different contingents, one with a high risk, other with the intermediate risk, and the other with low risk. So in low risk population, that is one in more than, if the risk is less than 1 in 1,000, you don't do anything. And in those who are having 1 in 50 or maybe 1 in 100 also, some people take it like that, so you need to act at that time only. And intermediate risk, you can either go in for NIPT or wait, or you can add certain software like these soft markers. So this soft markers you can add, and then you can decrease the risk also, as ma'am has explained very beautifully. So this is how it goes.
Yeah. So which algorithm will you use? Whether contingent screening?
Yeah. So contingent screening, as I said, contingent screening is better, because in contingent, see, there are two things. One is sequential, then integrated and contingent. So to understand the difference, and in integrated, you don't tell the patient report at all of the first trimester, and then you wait till the second trimester. So basically, it is very difficult for patients to wait and you are not giving any report. So this is not considered to be practically possible. Then comes the sequential screening, in which you take all patients who are high risk. You act at that time, or you take all patients who are intermediate and low, and you take them all to the second trimester. But here in contingent, you divide them into 3 parts. So this is about the contingent screening. And in contingent, in the intermediate risk part, we have added NIPT to increase the the broaden the effectiveness of NIPT, use of NIPT, and also to increase the detection rate at the same time. So again, the risk, as the risk can be taken as anything, 1 in 100 or 1 in 250 also by some people, but generally 1 in 50 is something in which we do invasive procedure, and 1 in 1000 is an intermediate risk in which you do some of the things, either NIPT most probably, and in 1 in 1000, less than that, you don't do anything.
Yes. So in our case, we proceeded with a PAP-A, which was 0.32 mom, and beta-HCG, which was 1.53. And the first trimester combined risk score was 1 in 67. So now what would you advise to this patient? Would you advise a quadruple test? Now I just want to prove, should we advise?
No, we should not. I think, as already said, it is less than 100. So you have to either go in for invasive test, or you can go even for NIPT. But going for quadruple test is not practically good, because it is less than 1 in 100. I mean, I would not go. It is free for, other people to think. Otherwise, even 1 in 50 has been taken as cutoff by some.
Yes, actually, whenever it is high risk, then we should not go in for a quadruple, because we really cannot reclassify and decrease the risk. But in case the risk is less, then as a part of sequential, you may. But if it is low risk, then you may do again, but not when it is a high risk. That is my take. Yes, but if it is high risk, then we cannot do a quadruple test.
True.
So next. So here in these cases, we can add other markers also, which ultrasound markers also, which has already been pointed out. That is ductus venosus and nasal bone can also be again addressed. Yes. So in few cases, we going for the diagnostic test. Is there an indication where we can directly go in for the invasive testing?
Yeah, we can go directly for invasive testing in, say, suppose a person is a carrier of balanced translocation, the parents. We go in directly for invasive testing. If they have already had a baby with Down syndrome, you can explain to them, like you counsel them. And if they say that I don't want to take any chance, then maybe you can go in for invasive test also. If the NT is very high, then you can, as already discussed, you have done the first trimester, NT is very high, more than 3.5, you can go in for invasive test directly. So, more than 95th or 99th percentile for the gestational age, you can go in for that. Or in absent nasal bone also, you can go in for invasive test. So there are many, and cystic hygroma is there. So any of these conditions, you can go in for invasive test directly.
Yes.
And if NT is very high, you can go in for CMA also. You can advise microarray rather than karyotyping.
Yes, definitely. We should offer a CMA, because that's then that's a then the geneticist will proceed with. But usually in case NT is normal, then we can go for CMA. If NT is very high, then karyotyping also may also be useful.
You can.
But if karyotyping is normal, then microarray. Right. So now for the next of the second case, I just hand over the next session to Dr. Sumitra Bachani. She will proceed with the discussion now.
Thank you, ma'am. So we just go on with the next case. We'll be, running short of time a bit. The second case is a 26-year-old primigravida, and her period of gestation is 12 weeks. CRL is out there. NT is 4.7. So the important thing is that it is above the 99th centile. And on the scan, there is no other structural anomaly. So the next question is to Dr. Sunita Verma. What is NT? Like for an obstetrician, generally when we are sitting in our clinics, we do get women who are our own patients. They come to us with the report. So what should we look at? Should we just read the report? do you think we should be at least, well versed enough to look at the images, and we should have a general idea as to whether that scan is a correct scan? Like here we are talking of, setting up the training and setting up the standards to do FMF certified scan. So what do you suggest? What should an obstetrician know about the NT?
So NT is actually the measurement, the sonographic measurement of the subcutaneous fluid that is present behind in the fetal neck, and which is best seen in the first trimester, as we discussed, with a CRL between 45 to 84 and preferably above 63. Now, whenever, at least when I get a patient, I always look at the scan, at the NT image, and you should make sure that it has been correctly taken. So one is that the screen should be occupied only by the fetal head and the upper part of the thorax. So it should be adequately magnified. You should not be able to see the whole fetus, the whole CRL. That way you see a lot of people with images where the whole CRL and the NT measurement is there, which is not correct. It should not be there. Then make sure you're able to identify as, we know that the nasal bone should be seen in that image. And you should be able to see those 3 white lines at the nasal bone. That's the nasal tip, the nasal skin, and the nasal bone. The palate should be seen, the diencephalon should be seen, and posteriorly you see the nuchal translucency. So that is how you know that this image is absolutely correct. Secondly, the fetus should be in the neutral position. So there should be some fluid between the chin and the chest of the fetus. It should be, so all this would tell you that it is a mid sagittal thing. It should be magnified either post, the ultrasonologist would do it after freezing or before freezing, but it should be adequately magnified. The position of the calipers is very important. The plus caliper should be used, and the horizontal bar of the caliper should be on the just above the line, the white line of the nuchal translucency. So when you look at the image itself, when you see many images, yes, this is a normal image and this is an abnormal image. And a thickened NT, it's very important to.
Yeah.
Sorry?
And what about other things that you should also be looking at?
So, this gives you a window, this time, this 11 to 13 plus 6 would give you a window of opportunity to look at other things also. You could be able to see a lot of, the neurological part of the fetus. You would be able to see even anencephaly can be recognized, omphalocele can be recognized at this time, megacystis, cystic hygroma. There's so many structural anomalies that you could be able to identify at this period.
Right.
And the sensitive, why this period is chosen is because 14 to 18 weeks sensitivity of nuchal translucency measurement goes down significantly as compared to before 14 weeks, 11 to 14 weeks. And obviously once you see the thickness, you would identify whether it is lying in your what is the centile as per the gestational age. So you look at the CRL, you look at the NT, and you come to the percentile measurement. And anything above 95th percentile is abnormal. Above 99th percentile is definitely severely abnormal and would be associated with more than 60% abnormalities in the fetus. But I would also like to add that increased nuchal thickness does not mean, by itself does not mean that the fetus, that it should be terminated. A lot of people, patients come to us in a panic mode. Oh, NT is 5 mm and I've been told that you should terminate the pregnancy. That is not true, because even at a 4 to 5 mm, you would find that around 70% would be healthy live births. So you have to sort of evaluate it further, go for invasive testing, look for other structural abnormalities, genetic syndromes, fetal infections. There are so many causes for an increased NT which you have to rule out before you come to this, that you would like to terminate. Even at an NT of 6 to 7 mm, 15% of babies would be healthy live births. So you have to be very careful when you, decide to terminate for this reason.
Yeah, we'll of course be discussing that further. Dr. Sunita, thank you so much for your inputs. And I go on to Dr. Reema now. Dr. Reema, please unmute yourself and take on from here, like when we do have a case coming in with an increased NT, at least as an obstetrician there, I mean, we should have some idea, what exactly it could relate to. So what do you think could be the majorly the reasons could be there for a thickened NT, which the obstetrician can use to counsel the couple?
Thank you, Dr. Sumitra. Well, NT, we all understand, is a very good marker for all common and uncommon aneuploidies as well, and a wide variety of genetic syndromes and structural abnormalities. So it depends on what is the cause of increased NT. We need to understand it could be a composition of the extracellular matrix, which could be because of achondrogenesis or because of achondroplasia. It could be because of lymphatic drainage, which is blocked in conditions like Noonan's syndrome, or there could be some congenital neuromuscular disorder or the akinesia deformation, which will lead to, spinal muscular atrophy. All of this, where movement is not happening, can cause increased NT. Some conditions like alpha thalassemia, Fanconi's anemia, parvovirus infection, hypoproteinemia because of congenital nephrotic syndrome. So considering that there are varied causes of increased NT, they could all be responsible for this condition. And therefore, when we think of increased NT, it's not just trisomy 21 or the major chromosomal abnormalities. We need to think of a lot of other uncommon aneuploidies. We need to think of 50 or more genetic syndromes. And even if a baby is chromosomally normal, the chances of a fetal demise are much higher in these babies. And there are a lot of association with a lot of other major defects. So when we get a patient with increased NT, there's a lot of counseling that goes with this patient.
So we can use this as a ready reckoner, maybe from the obstetrician point of view, before we start referring to a fetal medicine specialist, that, these are the majorly, syndromes or the aneuploidies or the conditions which can be associated. However, still there is a chance of having a good fetal outcome. So we can use this kind of, ready reckoner. So going further, other than the NT, like we were all discussing and we've been told that we can improve our detection rate. So we come to the various other markers. So could you just quickly tell us that shouldn't we ask for it when the patient comes back with an NT scan and doesn't have those things? Should we tell them that, you come back with these markers again?
So the markers which have been discussed by Dr. Anita, and she showed it very beautifully. See, when you have increased number of markers on ultrasound, you are actually changing your risk of trisomy 21 significantly. But we also need to remember that the assessment of these markers, like the tricuspid regurgitation, ductus venosus, nasal bone, requires adequate training and certification of competence, which we discussed. And therefore, there could be two strategies that we could have: either offer it to all patients where they can afford it, and otherwise as a secondary screening method, where if you have a subgroup of patients who come as high risk or maybe intermediate risk, we could offer these tests, these ultrasound markers to them, like the nasal bone, the DV, and the TR, which could get their risk down. And this is applicable to only 1/6 of the population. So the number of patients, especially when we talk of the government public setup, this could be a strategy that could be adopted.
Yeah, very
true. And also that if you have a DV or a DV changes or TR on your ultrasound, there are also markers for cardiac abnormalities. So if you have a fetus who's come chromosomally normal, we need to do an echo for these babies later in gestation to be sure that there are no cardiac abnormalities associated with them.
Yeah, thank you so much. So I think that is a very good input you've given, that ideally the radiologist or the fetal medicine specialist should be reporting these markers, shouldn't they? And if the patient comes back to us and she is especially falling in the intermediate category, the high risk probably, or a thickened NT, we would, otherwise also counsel for invasive. But I think these markers would then, reduce the risk. So you very rightly said that then we can always ask for more markers. So one of the ones which really causes a problem, and I've seen they come to us with an absent nasal bone and then they want a termination. So what should they be told? Like, should we do something in the first trimester, or we say that, well, we wait and see in the second trimester? We all know that the bone can sometimes,
So when you have an absent nasal bone, we need to know that 1 to 3% of euploid fetuses can also have an absent nasal bone, and 60% of those with trisomy 21. And of course, 50% with 18 and a few with 13. But what we is that at a 12-week scan, it could be absent, but this nasal bone could come up by 16 weeks. Right. So strategy one that we want to adopt is tell the patient that please come back at 16 weeks, reassess the nasal bone. If the nasal bone is present, then you really don't need to worry about it. Call her back for the anomaly scan. But if the nasal bone is not present in the 16-week scan, then you can offer either NIPT or invasive testing to the patient, depending on what the patient wants. So this is how I would like to go. But there are certain patients who are very apprehensive. On an ultrasound feature of an absent nasal bone, they directly want an NIPT in the first trimester. Well, this is a cafeteria approach, and you have to take whatever the patient wants at that point of time. But counseling is important. Call your back at 16 weeks and reassess the nasal bone.
And meanwhile, ask her to get an NIPT if she can afford.
If she can afford, she'll definitely get it done. But if you're talking of everybody, if the nasal bone comes back at 16 weeks, you really don't need to do any more testing. You just go ahead with your anomaly scan.
Right. So in case we do offer NIPS, I think we've had a very nice talk from Anita ma'am, and if ma'am is still around, maybe in the Q&A, we can bombard her with more questions. But what do you think, Dr. Reema, in a singleton pregnancy, where exactly do we fit in the NIPS?
Okay, so one thing is the interpretation of the report. One thing I want to clarify here is that we talk a lot about cell fraction. We've started trusting the reports more, where they say the cell fraction is 16%, 8%. We say that if the cell fraction is good, the probability of telling a negative report is much higher. But there's current literature that is coming in, which tells us that it's lab-based. The counting of the cell-free DNA depends upon the lab. So even a cell fraction of 4%, which a lab has reported, may be adequate. So when you look at the report, please see that the cell fraction is mentioned. We really don't need to look at the numbers, because each lab may have a different method of reporting. And secondly, it's already been discussed in great detail that a lot of factors modify the cell-free DNA. So obese patient, the cell-free fraction may be diluted. She's got active autoimmune disease. Again, her cell fraction may be lower. If she's got and another thing that is recently coming up is that we thought that if the cell fraction was no call, it would mean trisomy, but it's no longer holds true. It's not that if a fetus has trisomy, the report will come as no call. It's only with triploidy that such kind of report comes. So interpretation of the report becomes very important. And secondly, the most important question is that how does it fall in our routine practice? Well, I would say that cell-free DNA is best in the contingent screening for our country, at least. Yeah. If we come to a clientele who can afford everything, we can use it in the first trimester. We can use it as a primary screening test. It's all about money. But if we extrapolate it to our population, I think the contingent screening, which has been discussed in great detail by Dr. Anita, I think that's the best way we need to go forward.
Right, true. So, Dr. Sunita, can you just summarize? So there is this patient with a thickened NT more than 99 centile. So what would you just explain to her? What she should do and what she shouldn't do? She's definitely, right now, there's no role for going in for an IPS. So can you just summarize this, please?
Okay. So an increased nuchal translucency is one marker which overrides this risk and the marker concept. This means an increased NT. Once you have confirmed that it is actually increased and you have confirmed the CRL, one must go for invasive testing, because this is one of the high risk markers. Almost 75% of Down syndrome babies have an increase in nuchal translucency, and also, you can, in this case, of course, there's an isolated increased nuchal translucency, but there are other markers also, like, for example, an omphaloceal or a megacystis or a cardiac anomaly or ventriculomegaly, echogenic bowel. These are all which, markers, major markers, which have high likelihood ratios for aneuploidy. So they would all warrant invasive testing rather than a biochemistry or an NIPT.
So the result is that we counsel her for invasive, and accordingly we may go in for a microarray or an exome if our array turns out to be normal. So thank you so much. We move on to the third case. I think Dr. Jaya has been waiting very patiently.
Dr. Smitra, I'll just add on one thing. Between the 95th to the 99 centile, whether we should offer invasive or NIPT, that was a question you asked me. Here, see, invasive testing, actually now with a lot of literature coming up by the Scandinavian group and by Biomarker, we feel that invasive would be the right way forward, even between the 95th to the 99 centile, because 1 in 7 to 1 in 14 risk of certain chromosomal aberrations may be missed if we offer only NIPT to these patients.
True. Thank you so much for the input. Yes. So we go ahead with invasives. if NT is more than 95th centile. So we go on to case 3, Dr. Jaya. So this is a 34-year-old lady, and she's coming to us at 10 weeks. She's a bit concerned because her previous baby had Down syndrome. Now, we all know that she wants an early detection. It's also a very precious pregnancy. She doesn't want, any risk of miscarriage. So I think, what do you say, that this is the right candidate to undergo NIPS? Dr. Jaya, unmute yourself, please. Dr. Jaya? Dr. Jaya, we can't hear you. No, you're not audible. Not to me. Is she audible to anyone? No, you're not audible.
She's not audible to anyone, not even us.
Jaya?
Some problem with her microphone.
Himanshu, can you see if you can unmute Dr. Jaya, please? Is there something from your end, Himanshu?
She is unmuted.
Can you re-log in, Dr. Jaya? Meanwhile, so I think we've already had a great discussion on NIPS, and ideally, as we are discussing that in contingent, you should be using it as a contingent screen. But I just wanted to get the input from Dr. Jaya that in this case, if a patient who's not willing to take on the risk of invasive testing, and she still falls, since she will be a high risk category, she has a previous baby with Down syndrome. Till Jaya, I think, is able to. Would you like to take this, Dr. Reema? I think Dr. Jaya is probably.
Yeah, so what we've discussed is that non-invasive NIPS is a very good screening tool, 99% sensitivity, and it can be used in contingent screening. But if your patient is not willing for an invasive testing, NIPS can be done with the counseling of the patient, that if the scan is normal, echo is done, which is normal, we've ruled out all the anomalies, NIPS may still miss out on 2.5% of chromosomal abnormalities, which has to be counseled to the patient. With this counseling, we can go ahead with NIPS as well.
Okay, Jaya, have you logged in? Have you unmuted, Dr. Jaya?
Dr. Sumitra, can I say something here for your last slide?
Yes.
See, we should never offer two testings together. We should never offer a combined testing and NIPT together to a patient. This should always be remembered. NIPS can always follow a combined first trimester screening in case the woman falls into a intermediate risk category, or maybe if she's a high risk, she doesn't want to have invasive, but should never be done simultaneously. And once a patient is NIPS high risk, she should never be offered a combined first trimester screening, because
so that's what, ma'am, is happening. We are getting so many.
Yeah, this is really what is happening across.
Yes, that's why I put it across.
Yeah, that is why we should never. And secondly, once a patient is high risk at first trimester screening, she should never be reassessed with a second trimester quad, because these are the common things which are happening in practice. So these messages should go very clearly.
Yes. So
can I add
one thing? To do a combined first trimester screen, and if the screen is low risk, nothing more to be done. Please don't go screening again and again.
And even if it is high risk, please don't try to recalculate the risk of the patient with the quad screen. Yes. People should not mix these two things. If you're going for a integrated screening or a sequential screening, that is completely a different ballgame. And we should always remember that in a sequential or integrated screening, you have to use the same software which was used for the first trimester screening when you are doing the second trimester screen, same lab.
Yes.
Dr. Jaya, can you talk about the limitations of NIPS? I think all of us have been talking about where to use, so we should also know what are the limitations.
Yes, of course. First of all, it is very necessary to impress upon the candidate that not only is it a screening, it's a targeted screening. Because whenever we offer any kind of screening protocol, more especially the NIPS, the people go home with the idea that they're going to have a designer baby, absolutely flawless in terms of genetic conditions and otherwise. So it is very, very important to tell them that there can be false positives, there can be false negatives, there can be test failures. So this kind of counseling at the very beginning, precludes a lot of disappointment once a test is taken. Here, I would like to emphasize that they should be told that even if a test turns out to be, the test is not going to be giving them an idea about the baby is Downs positive or Downs negative. It's going to give them a low risk or a high risk. That is the first idea they should go home with. The second is that if they get a baby who turns out to be high risk, again, there is a margin of error. It could be a false positive based on the conditions that have been enumerated here, like mosaicism, like a maternal malignancy, like, for example, a vanishing twin. So here I would like to emphasize that even if a couple opts out of a combined first trimester screening and moves towards an NIPS, it is only the biochemical part of the combined first trimester screening that can be done away with and not the scan. Because the scan can give us very valuable information about whether she still fits into the candidate of being an NIPS candidate, or she has to go towards invasive testing. Like, for example, if she had a baby with Down syndrome and she herself was carrying some kind of a translocation, then she would straight away merit an invasive testing rather than going for NIPS. Similarly, her BMI might preclude her chances because the test failure would increase in that case. A vanishing twin could be picked up on early scans, which would again lead us to more invasive testing rather than NIPS. So all these are conditions that should be discussed in detail with them. Maternal age, 2% per year. When we talk of BMI, 5% per kg body weight. These are conditions in Southeast Asian ethnicity in itself is associated with a high test failure rate. So all these conditions should be discussed with the mother in great detail. And then, of course, if the mother decides to go in for invasive, that case should be respected.
Okay, thank you. So there's just one offhand question which comes into my mind, that if there is a vanishing twin, would you advise a biochemistry or a NIPS maybe after 2 weeks? Would you think the serum levels?
Well, in case of NIPS, a vanishing twin is associated with an increased incidence of no call. That has to be told to her. If she's prepared to take that kind of a risk, then she might opt for it. We will, insofar as the combined first trimester screening is concerned, there has to be a gap of a little more than that, maybe around say 4 to 5 weeks before she can actually become a candidate. And since time frames are going to be extremely important, here, of course, she's fortunate to be coming at 10 weeks, but most of the cases that we all see actually happen to come a little later. So in that case, if we are not able to fit into the time frame of that particular test, then that would affect our choice of the protocol that we follow.
Probably moving into the second trimester by that time.
Yes. So in that case, an invasive probably would address the situation better.
So we go on to the next case. A primi gravida comes for advice at 12 weeks with an ultrasound report, which again, most times we get this kind of a report. It just says twin pregnancy. So again, as obstetricians, at least we should be demanding some certain, in a case of a scan which has been done for a twin, what are the parameters which have to be mentioned, without which such a scan should not be, accepted? So what all would you tell her or talk to her? Just crisp, very short and crisp answers.
See, I think all the other parameters that we need to see in terms of aneuploidy have already been discussed. So insofar as twin pregnancy is concerned, chorionicity and amnionicity is something that we absolutely cannot compromise upon. So that needs to be mentioned for sure. And it does not has to be mentioned. It has to be accompanied by a film, which can be reviewed at a later date by any other person. So if that is not there, then fortunately, we are at a window of 12 weeks where the scan should absolutely be repeated in case it is falling short on this parameter. Secondly, a multifetal gestation is at a high risk for hypertensive disorders of pregnancy. So having a preeclampsia screening in terms of uterine artery Dopplers would serve us a long way in this particular case.
But this panel is, of course, about aneuploidy. So could we also could we talk about screening for aneuploidies in twins?
Yes, of course.
Yeah, so
here again, we have to understand certain very basic concepts, which are, of course, clear by now. But just to reiterate some of them, that zygosity is prime importance, because in terms of chromosomal abnormalities, we normally talk of a risk of 3% in terms of chromosomal abnormalities for singleton pregnancies. So when we compare twin pregnancies with a singleton pregnancy, we have to understand that a monozygotic twin pregnancy is technically like a singleton pregnancy. in terms of the genetic constitution. So the same risk applies to monozygotic twins. But in case of a dizygotic pregnancy, it is like having two different singleton pregnancies incidentally at the same time. So therefore, the risk of having a chromosomal abnormality in these cases turns out to be 6%. Thereafter, we have to understand that for a monochorionic pregnancy here on, because we would not be able to determine whether it is a monozygous pregnancy. So a monochorionic pregnancy is going to have a detection rate of say 90% with a combined first trimester screen, with a false positive rate of 8%, because it is technically high, because the anti-discordance between these twins can partially be attributable to a risk of TTTS in times to come. In dizygotic cases, since these are like two typical singleton pregnancies, the false positive rate would be 3% per fetus, and therefore would be to the tune of 6%. Again, for a detection of 90% in combined first trimester screening. So the first take home is that twin pregnancies are still candidates for a combined first trimester screening with an equal probability of getting a decent detection rate. So that is one idea. The second idea is that they are also candidates for NIPS. Again, the same rules hold good in this case also, that even if a candidate is opting for an NIPS, only the biochemical part of the combined first trimester screening goes away, and the scan is very, very importantly retained, because again, it tells us about a vanishing twin, which might tilt us in the favor of an invasive testing. A chorionicity would be important because whenever we talk of combined, an NIPS in cases of twin pregnancy, we must understand that the performance of the test for trisomy 21 is comparable to that of singleton pregnancies. But in cases of trisomy 18 and trisomy 13, we do have encouraging data at the moment, but we would like to have more data dropping in before we endorse them as well as we do it for trisomy 21, number one. Number two, the failure rate or the no call in these cases is likely to be very high. Again, here I would like to emphasize that if for a singleton pregnancy, we talk of a failure rate of about 3% for an IPS, then for a dizygotic twin, this can actually go as high as 13%. So this has to be emphasized from the word go in terms of a pre-test counseling, so as to set reasonable expectations from the test and not have a disappointment later.
So NT plus biochemistry or NT plus NIPS with adequate counseling, right?
Yes. And one more thing which I would like to emphasize here, which is yet to be discussed so far, is the methodology of taking the NIPS. We can have a massive parallel sequencing and we can have a SNP based assays. Now the difference is that most of
We'll discuss that once, I think another case is there. So after that, we can discuss that, Dr. Jaya.
Sure.
Okay, thank you. So for the NIPS, as we've already discussed, that it is being validated for trisomy 21 in twin pregnancy, not for 13, 18 yet. So may I request Renu ma'am to take over from the fifth case, please? And we have 10 minutes, ma'am. We had quite a number of deliberations, so we have 10 minutes, yeah. Please unmute yourself, ma'am.
We'll briefly discuss two more cases. So case 5 is a spontaneous conception. It is diagnosed to be monochorionic diamniotic twin at 12 weeks of pregnancy with discordant NT. That is, in the first baby, NT was 4.2 and the second baby has an NT of 1.8. Dr. Manisha, how will you counsel her? And now couple wants to opt for termination. Should you advise them that they can go in for termination in this case?
Yeah. So as you have already mentioned, ma'am, that the NTs are discordant. So whenever there's more than 20% difference, so discordancy means apart from, say, the chromosomal and the possibility of having some malformation, it means that there is high probability of TTTS, we have to remember, and stillbirth also. So we have to, these two things also gets added to it. And certainly without any test, I would not advise termination. And then we can go in for tests. And that test includes getting the invasive test done. And apart from that, we can go in for frequent scans for TTTS occurrence, and then laser, of course, at around early age of 16 weeks or so. So that is something that needs to be told, and that's it.
Would you like to
If
advise
any,
invasive from both for both or for?
Yeah, for both.
Because one
Basically,
end is normal.
the zygosity, yeah, we don't know. I mean, some people say that we can do it for one, but generally, I prefer both. And I think we can take the opinion of others also, but generally, I do both.
yeah, I think it should be for both. It's a monochorionic, so I feel we should go in. Yeah, here, if it is monochorionic and we are sure that it is monochorionic, then one can suffice.
I know Dr. Sangeeta can
Dr.
add because
Sangeeta?
I generally I take both the sides.
I prefer to take both sample both on both sides, either ends of the placenta, and it sometimes depends on the access also. You may not have access of the other end of the placenta.
Even in monochorionic?
Yeah, because discordance in monochorionic twins has also has been reported in literature.
And I would prefer CMA rather than doing karyotype.
Absolutely, especially because NT is increased.
Because yes, NT is high, yes. In this case, definitely in twin pregnancy. So how does the NPS work in twins? I think, Sumitra.
Does it work for these? So I think we've already had a discussion on that. So
yeah, so then we'll skip these slides, 2 slides. Yeah, now case 6. So Mrs. S, who is 42 years old, she's G2, P1, L1, and she's now 12 weeks pregnancy. She wants to rule out T21 because she knows she's at a higher risk. Then what will you advise her? She doesn't want invasive procedure.
Sometimes these kind of patients, they just get a NIPT done. They've probably had a an IVF conception at 42. They come to us with a NIPT report, and that's the end of it.
So that may be likely because she only is L1.
Before this, some more information which I would like to dig into is, since she's an IVF at 42, it's very likely that it could be a donor egg. So the age a priori risk of of this pregnancy for aneuploidy will then be the age of the mother who has donated, the woman who has donated this egg and not 42. So that's the first thing which I want to point out. Number 2, again, I should have a scan to look for the number of fetuses because IVF, again, multiple pregnancies. If multiple, there's a chorionic or monochorionic. So considering that probably this pregnancy is a singleton pregnancy, the options which can be given to the woman who's not, why should a woman have an invasive test at the first go, in fact? So it's between a combined first trimester screening and an NIPS.
Yeah, so she doesn't want invasive, so then she can go in, or we can offer her combined FT screening or NIPS. But then we have to be sure that there is no vanishing twin, and that also needs to be mentioned. And all other that you have already discussed should also be mentioned and discussed with the woman in detail, so that she has not hidden another comorbidities like diabetes.
Dr. Renu, one thing which I want to say here is that if there is a vanishing twin, then I'll tilt my screening methodology probably to a combined first trimester screening and not an NIPS. If there is an availability of 2 weeks interval between the documentation of the vanishing twin and my aneuploidy screening for biochemical screening for within the first trimester.
Yes, and we can evaluate the fetus timeline. Yes, and we can evaluate
not just 2 weeks. The literature says that it can be almost up to 4 to even up sometimes 7 weeks, and NIPS should not be done in vanishing twins because the placenta can keep the placental DNA will be thrown into the circulation even up to 7 to 8 weeks, and by that time we'll lose on time which a woman would need to make her reproductive options. So if it is a vanishing twin, then I'll not keep NIPS as one of my options.
Yeah, exactly.
So she had come in with the NIPS.
I think, Dr. Renu, here a combined first trimester screening is a reasonable option.
We can
for the
expand
women.
also. We can expand
NIPS again, in IVF, NIPS again can have a higher result of failing and all. So you have to tell the couple of all the advantages and disadvantages, keeping in perspective her own clinical profile. And at the end, the couple has to make the choice.
choice.
Yeah, and moreover, we can expand the ultrasound parameters also that already has been discussed, and also we can add for the
ultrasound,
because then
and
then results are comparable.
One more thing one more thing, that whether you do an NIPS or you don't do an NIPS, ultrasound is something which cannot be done without. So you have to do an ultrasound irrespective of your modality of screening.
Yeah, we can
and it should always precede your NIPS or biochemistry.
Yes, and also we can make it expanded biochemical test, and then thereby the predictability and sensitivity will increase to almost same as NIPS. So that also is an option which is available with us, and actually with time we will improve. Now I invite Dr. Sumitra to summarize and to conclude the session.
Ma'am, I think we already short of time. I think we have such experts with us. So maybe if Dr. Seema Thakur.
Dr. Seema, yes, she can also add on.
I would invite her for her expert comments, and we have a couple of minutes for any other points. I think if Jaya wants to share.
We'll just see if there are any questions in the chat box.
And Seema Thakur madam is there?
Yes, yes. So you can, okay, just a minute. Yeah. So it was a wonderful panel discussion, Dr. Sumitra and Dr. Renu. And I think you have covered almost everything, beginning from the, what are the parameters which should be given, factors which will affect the dual marker or the quadruple marker, then including the norms, the result, and their interpretations, and the importance of the ultrasound. So one thing which, which I feel is the most important, that, we have to add both of them, they give equal importance to the ultrasound and to the biochemistry also. So it's not only about the biochemical marker and not only about the ultrasound. It is the complete, both the thing combined should be added together, and that is the most important message, that the ultrasound should be, because they are complementary to each other. Biochemistry gives us different informations, and ultrasound gives us different information. So we should not be, categorically saying that yes, it's the only the ultrasound standards or only the biochemistry standards. It is both which has to be taken together so as to benefit every woman, because as I discussed that, it's every woman's right to have, the baby which is healthy. So that's what I wanted to say. It is a combined assessment, and depending upon the situation where you are, you can discuss with them. And being very neutral and giving them choices sometimes doesn't work much. At times we should be little, directive, that because these women, many of the women, they will not understand these risk assessment. So the risk 1 in 100 doesn't mean much to them. So we'll have to tell them the risk is 1%, right? And one most important figure which I want everybody to learn, that whenever there is a positive quadruple or dual marker test and the ultrasound novel, so one should counsel them that the risk of the odds of projective, being positive, which Dr. Vatsala has already highlighted, that one has to say that the risk is only 2 to 3% to have a baby with Down syndrome. So that message, because I have seen them in a panic condition, in stressful situation. So these are a few important things which so everything well covered, Dr. Renu and Dr. Sumitra. A big congratulations to you. I'm amazed, the kind of practical issues which you have raised. So that made me really feel very glad at the back end. So I must congratulate both of you. Done very hard.
One question I have, madam, is that since we have such esteemed, panelists with us and speakers, and all of you are experts, like we should have a cutoff determined for our population.
Yes.
We go in for what is high risk, what is intermediate risk for us. I mean, should we follow the FMF?
I tell you, actually, long ago, Gangaram published a paper and they have used the cutoff 250 to 1500. And since maybe more than 10 years, I have been using 1500 as my cutoff and by God's grace, it has been okay with me. I have never come across. And of course, I give equal importance to the ultrasound also. So check both the things individually, very minutely. But yes, 1 in 1500 is good number where you can say, and in the other where not good ultrasound, you can say 2000. So that is the, important, the 250 to 1500 is more or less which is I'm being, using. So that gives me
screening, yes.
And I have seen in intermediate risk actually 3 cases of Down syndrome in intermediate cases. One had 750 risk, one had 800 risk. So it's not just that we are extra using NIPT, and probably if we start using more number of NIPT, because this is no denying, the progress should be accepted. Any progress like fetal medicine progress, the genetic progress, that should be accepted, that there is no denial that this is the one of the best tests of the century, so we have to utilize it judiciously. So the cutoff should be used, and it can be widened. In your case, like in government setup, you can stretch it up to 2,000 because you don't have much ultrasound power, manpower, or also the so all these, these are important. That NIPS has, the change is already taken place. It's the time we have to utilize it judiciously so as to make it cost effective. And once we start using in a quality manner, really the cost will come down. You would remember it was 60,000 long ago when it was started, and now this has come to 10,000 as well. So probably we want to make it to 5,000. Yeah, so that's what the goal is.
Can I just make a point, Dr. Seema, Dr.
Yes,
Sumitra?
yes.
So actually what we are talking about, the combined first trimester screen, the contingent plan to do cell-free fetal DNA. So we know that the fetal DNA in the maternal plasma circulation arises from the apoptotic placental trophoblastic cells. So basically we are looking at the placental pattern. Normally placental and fetal chromosomes will correspond, but there can be cases of mosaicism. So there are some situations in which even following a chorion sampling and amniocentesis may be dictated, because an amnio is actually picking up fetal cells. So can I have the experts' opinions on this?
Dr. Sanjeevni, in cases of the normal ultrasound finding and when biochemical problem beta HCG is high, I prefer going in for amniocentesis rather than CVS. So that is what my take. Even if it is dual test and it is shown to be
Recently we
high,
had a
prefer
case
doing
that in the placental tissue and the amniotic fluid, ma'am has rightly pointed out that they at times can be different. So, recently, fortunately, that baby didn't turn out to be Down syndrome, but when the child was born and with developmental delay at 6 months, the child was exactly looking like Down syndrome, and I had goosebumps, for all those past 15 days. And fortunately, now the fish and karyotype is okay. In this case, the NT was about 4.5 millimeter, and the CVS was performed considering the high risk. And the CVS, the whole exam, everything microarray was within normal limit. And when the child is born, the child has got developmental delay. So that made me think, should I revise? Should I start doing amniocentesis? Because very rarely they can be discordant, and you can fall in situation like me.
That is the point I wanted to bring out. And also because cell-free fetal cell-free DNA is like taken as a fetal.
And they recommend amnio only.
Also placental product
of this thing CVS.
Yeah.
So CVS and cell-free fetal DNA is like almost parallel if you're following the first trimester screening and contingent screening protocol. So there may not be much difference between that report, contingent report, and the chorion sampling report, because you are testing placental cells. So if you want to see fetal cells, then you might as well go wait a bit and go for amnio. And that also now
for
that
positive NIPT, ma'am, they recommend amnio only for positive NIPT.
Yeah.
So I feel that, whenever for Down syndrome, probably amniocentesis is a better answer. But currently, what has happened, ma'am, these are all molecular tests. So at 16 weeks, you may not have enough cells. So that again,
17 weeks. So good.
Yeah, so better is the 17 weeks.
So now that our MTP guidelines are, have changed, and so we can be a little easy.
Yes, even I feel that we can start doing at 17 to 18 weeks, not rushing like 16 weeks, because at times we had to repeat the test because of the unavailability of the cells.
Yeah, but if you from an obstetrician's perspective, if you have an anterior placenta which is covering completely the anterior wall, then you have a difficult decision to make.
By 18 weeks, you'll have one window. By 18 weeks, you'll have. At 16 weeks, it becomes tough. It may become bloody.
Renu, Dr. Sumitra, and of course, all the conveners, Dr. Seema, Dr. Sangeeta Gupta, and Dr. Achla, of course, can't miss her. All of you, Renu, and that too
speakers
from overseas. I think you have just done a wonderful job in this early hours of yours, and sacrificing this time on your holiday time. And once again, thanks to all of you from my side, and for Dr. Achla Batra especially, because you see she's been putting us into so much academic and academico-clinical activities that I don't think we've had this propulsive effect so much to this intensity. And really grateful for
Yes,
Dr.
I second that.
Dr. Rima, Dr.
I need to.
Sunita,
Yeah.
everybody, Dr. Bindu Bajaj, Dr. Jyotsna, Anjali Dabral, everyone. I think, together it has been a program, and we've all been in sync with each other. And it may have sounded a dry subject some years ago, but thanks to you all, with so much dedicated efforts, that it does not sound dry or dull anymore. In fact, it feels like a responsibility, a duty. So thank you from my side.
And the prevention of Down syndrome paves way for other prevention, like for trisomy 18, 13, at times increased NT can be in other genetic syndromes. So it is the mother of the prevention. And this, along with this, you can prevent so many other disorders. It's not only about the Down syndrome. When you are very, quality dependent on the Down syndrome, then probably you'll add more to the prevention of the genetic disorders, because nowadays because we have vast populations. So the incidence of genetic disorder is high. Initially we were not seeing, but now once we have started working, we have started seeing many of the rare genetic disorders which I had just read long ago.
And translucency, then as Dr. Sunita Verma had mentioned in detail, the nuchal translucency. So it is not, only the translucency in the region of the neck, but we've got to track the entire spine, because there may be a cystic hygroma. So there may be other things, so we have to be very thorough with the ultrasound examination.
The NT scan has really advanced now. It is able to detect so many things which we were not able to see before 18, 20 weeks earlier.
It is Down syndrome and beyond, actually.
Yes, actually.
Actually, no, I would just getting beyond the topic. The purpose of all these webinars is because I really this time tried to handpick people, who were good. And that's why I have a good, army of chairpersons. And like topics like this, we, as general obstetrician, we want to know what is right. Everybody is doing NT. Now you send somebody for a 11 to 13 weeks trial, anybody is doing NT. But like it has been highlighted in today's webinar, how it has to be done. So when we are interpreting that NT, we have to know, who is doing it. So that is very important, just seeing a NT which is more, maybe it has not been done correctly. So that point is also very important, that general obstetricians should know that these two scans, the level 2 scan and the 11 to 13 week scan, they should not just get it done from anybody, but from a certified ultrasonologist who would be giving correct results. And I think today's webinar has been really good from the point of view of general obstetrician, because these are all the queries which keep coming to everybody's minds, and many of them have been resolved. So all in all, it has been really good.
Thank you, Dr. Seema, also for giving us this opportunity and having a faith in us. Thank you very much. And I thank all the speakers and also all the panelists and all the chairpersons for this session. Thank you very much. I think Dr. Sangeeta wanted to say something in between in case.
No, I thought we should take this opportunity to reiterate it to all of us that we are so, so much into aneuploidy screening, but in first trimester or first visits itself, one thalassemia hemoglobinopathy screening is very, very important in this part of the world. There is a significant burden of hemoglobinopathies.
I agree.
And
yes.
second, preeclampsia is also, now we have such a good method to screen for preeclampsia. Just adding one marker in the ultrasound, even if you can't do PLGF, and otherwise it's all maternal history and MAP, that is checking the BP. So now that should also be incorporated into our day-to-day practice. I know public sector, private sector, no issues. They take care of everything. But in a public sector, we need to bring these two also in a big way. That's what is my agenda now, that hemoglobinopathy screening and preeclampsia screening should be pushed in a big way in the private sector
We are definitely, even in Sabdarjung, we are trying to put this also as an important test.
The second week of January, I'm going to have something on THT.
Great
good talk on that. Yeah.
I think ma'am has done my job. Renu ma'am has, I thank all of you, and I thank Achla ma'am and all the chairpersons and the, really dear panelists for their wonderful inputs, and our experts, Dr. Seema, Dr. Sanjini ma'am, and our co-chair for the AOGD Fetal Medicine Subcommittee, Dr. Sangeeta Gupta ma'am. And I really thank the audience for being there with us, because without them, this wouldn't have been possible. And their inputs, which were all there in the chat box. And most of the questions, all of them, I think, in the chat box have been addressed. And I also would like to thank Suchanna and Anna for coordinating this with us. And especially thank Dr. Renu for joining us from the US. And
that was my pleasure. Actually, I'm enjoying it.
And I thank Shivam for the back-end support that he has provided. Thank you all very much.
Thank you.
Thank you so very much. Thank you.
Dr. Sumitra sponsors. Our sponsors. Yeah.
Yes. So I thank LifeCell and Perkin Elma. Both of them have been our supporters and sponsors, and I really thank them.
Thank you, everyone. Bye.
Thank you. Thank you for reminding me, ma'am.
No, they are important. Other than next time they'll get annoyed with me.
Thank you.
Yeah, that happens. That happens. Okay. Bye, everyone. Thank you.
Bye.
Bye.
Thank you, ma'am. Bye, ma'am.
Bye.